Good morning, Chair Murphy, Ranking Member DeGette, and other distinguished members of the subcommittee. Thank you for the invitation to share with the subcommittee opportunities to better protect Medicaid and Medicare from unscrupulous providers and improper payments. As you mentioned in your opening statement, Chair Murphy, Medicaid and Medicare reported a combined $89 billion in improper payments. In addition, OIG found that HHS missed important performance targets. For example, Medicare fee-for-service reported an improper payment rate of 12%, exceeding the 10% goal established by law. Medicaid also reported an error rate higher than its established target. These findings indicate that HHS must redouble its efforts to pay the right provider, the right amount, for the right service. And provider enrollment is where it starts. Enrollment is the green light to start billing. To get that green light, providers need to clear the provider enrollment process. So the provider enrollment process is Medicaid and Medicare's chance to make sure they are not doing business with those whose business it is to commit fraud. No one wants Medicare doing business with abusive and fraudulent providers like Dr. Fatah, the oncologist who administered aggressive cancer treatments to patients who did not need them simply to increase his billing. Or Medicaid paying Small Smiles, a dental chain performing unneeded root canals on children. To help prevent these sort of egregious cases of beneficiary harm and improper payments, Congress, through the Affordable Care Act, authorized a more rigorous, risk-based approach to screening providers. As a result, provider types deemed by CMS to be a higher risk are now required to undergo site visits and sometimes criminal background checks. Today, I want to talk about how these ACA tools were implemented in Medicaid and in Medicare, and also the problems we found with the databases that support these important tools. For Medicaid, we found that state implementation of enhanced provider screening is incomplete for higher risk providers, leaving Medicaid vulnerable. We found that most states have not yet started conducting criminal background checks while waiting for additional guidance from CMS. Further, 11 states are not conducting site visits. OIG recommends that CMS assist states by offering guidance, technical assistance, and improving the ability of states to rely on Medicare screening results so they don't need to duplicate that work. For Medicare, we found that CMS's implementation of enhanced enrollment screening needs strengthening. In particular, we found that contractors were inconsistent in applying site visit procedures and not always using site visit results in enrollment decisions. The OIG recommends improving the process by improving the site visit forms, additional training, and ensuring the consistent use of site visit results in enrollment decisions. OIG's reviews also found questionable data in Medicare's provider enrollment database. We frequently found different information when comparing owner names in Medicare and Medicaid databases. In one case, for the same provider, Medicare had 14 owners listed, while Medicaid had 63. It is hard to know who you're doing business with if you can't even get their names straight. CMS and states are also lacking complete data on providers terminated for reasons of fraud, integrity, or quality, because not all states are reporting that information. As a result, states may enroll a provider that's already been terminated in another state. In fact, we found 12% of providers terminated in one state continued to participate in Medicaid and other state Medicaid programs. OIG recommends that states' reporting of terminated providers to a centralized CMS database be made mandatory. CMS agreed that our recommendations would strengthen provider enrollment, and as such, we believe they should be undertaken immediately. In the longer term, we suggest CMS consider working towards consolidating Medicaid and Medicare provider enrollment, believing that it could lead to a more effective and less burdensome enrollment process. In closing, I would like to say thank you to the subcommittee for your recognition that provider enrollment is critically important through your holding of this hearing and also your congressional action on H.R. 3716, the Ensuring Access to Quality Medicaid Providers Act. We certainly hope that our work serves as a catalyst for additional positive change to ensure that CMS and states are paying the right provider the right amount for the right service. Thank you.